Oh, okay. Go ahead.
Cool. So, ladies and gentlemen, welcome to the Knowledge Exchange podcast. I'm your host for today, Daniel, one of the mentors and educators at the Knowledge Exchange. And we are lucky enough to be joined by Mr. Walt Fritz, all the way from the other side of the globe. So, Walt, whereabouts are you exactly at the moment?
I'm in my office right now, but that's in the area of Rochester, New York, which is about 5.5 hours west of New York City, upstate New York.
Awesome. So
Yeah.
a little bit far from Manhattan.
Yeah, about 5-6 hours. Yes. Yep.
Awesome. Cool. So Walt has been hugely influential in the way that I tend to view manual therapy nowadays. I've had plenty of discussions with people who've taken his course, and I've looked into the resources that he provides. I really admire his approach. So I know that there's going to be some valuable takeaways here from not only the manual therapists, but the exercise movement-based professionals, so that we can have a kind of common language when we talk about working with patients with pain. So really excited today to pick your brain, Walt.
Great. Well, thanks for having me. First of all, before I say anything, I want to kind of pass along my condolences, if you will, for what's going on in your country right now. I've been there a few times in the last couple of years, and it's just it's heartbreaking. It's got to be for you living there as well. And anyway, my thoughts are with you right now. So.
Thank you for that. Thank you. It's a tough time at the moment.
Yeah.
So Walt, I like to ask this question. It's a Peter O'Sullivan-esque question. What's your story?
My story. I'm a physical therapist. I've been one for a long time now. 1985, started in the physical therapy profession. I kind of did a smattering, a lot of different things: pediatrics, early intervention, general hospital, developmental disabilities, home care, kind of the gamut of what a PT can do, at least around here. In 1992, I started my manual therapy saga, my myofascial release saga, jumping down the rabbit hole of myofascial release and lesser so to cranial psychotherapy. And I got sucked into that rabbit hole, head first, feet sticking out, and never left for a couple decades, meaning I bought into the fascial narrative. I bought into the emotions are stored in fascia. I bought into we're the only ones that can truly heal a patient. A lot of really, really bad stories, but I was not a very good critical thinker, and I went there. So I was, I learned a lot. I learned some very good skills with my hands. I think I learned some pretty bad skills with my brain in terms of how I assessed what I was doing, how I assessed the evidence, how I dismissed evidence that really didn't confirm my bias. And that's a big part of my story and why I'm here. And then about almost 15 years ago now, I left / got kicked out of that rabbit hole, that myofascial rabbit hole. Depends on who you ask whether they say I left or got kicked out. But that's a story for another podcast. I met some people along the way that kind of mentored me, crossing the chasm, as some people like to say, from that tissue-based story, the fascia-based story, into neurologic narratives, into behavioral narratives, into maybe looking at the cascade of influencers that can be at play when we do manual therapy, when we do exercise-based therapy, heck, when we engage with a human being, right? Instead of it being about one story, it's a multitude of stories. And I love that right now. I love the uncertainty of our profession. I love teaching uncertainty. I love watching people squirm with uncertainty, because we're not used to that. We're used to thinking, okay, right now I'm affecting, I'm affecting that joint. I'm affecting that trigger point. I'm doing this for weakness, right? Without realizing that, there's a head and a brain and a central nervous system and a history and attached to that. And I love that uncertainty and working from there. So that's who I am right now. It's about teaching a model of manual therapy that honors the uncertainty, but looking at the plausible explanations for what might be at play.
It's amazing. So going from a few rabbit holes, going from 20 years of kind of you had kind of certain narratives as to what you were doing, why you were doing it. You had a certain story, and then it sounds like your worldview was crashed. So that sounded like
Yeah, yeah, very much so.
And
And it was hard to take.
Yeah. I was going to say, what were the kind of, if you can recall, as long as there's not too much trauma involved, if you recall that era, what would you say were your thought processes during that time? Because I imagine there would have been a bit of backfire.
There was a lot of rebellion on my part, a lot of pushback. There's at least a semi-famous thread on a forum site called Soma Simple that sort of categorizes my demise, or at least categorizes who I was before. Myofascial release, the great conversation, unfortunately has been viewed by a lot of people. I say unfortunately because it really shows me behaving like an ass in terms of being so pig-headed of what I was taught and not listening to what some really smart people were offering up to me. Now, they don't have all the answers either. They didn't. Nobody really does, right? But that was really hard. That was hard because it went nowhere. But then after that, once I left that community, trying to figure out, okay, here's all these other stories of what happens when we do manual therapy, whether it's, it doesn't matter, any kind of manual therapy. When we touch a human being, all these different stories of what's happening, it was tough to wade through. And it took me a good 10 years to kind of get to where I am. And that's, I'm not committing to one story. I'm committing to knowing it could be a lot of different things. Ultimately, that's why I've developed kind of the approach that I do. Instead of it being about the tissue-based story, or even that muscle or exercise or weakness or strengthening based story, I make it about the patient themselves and what they feel would be beneficial to them. I demand that my patients be a full and active participant with my process, about the therapeutic alliance that we build with each other, that the relationship is what we build and how they help me determine what will be helpful for them versus me telling what's best for them.
It's amazing. It's a two-way street. It's always a bit of a dance between what they think is the problem and what you see, what is presented to you, and how they respond and react to your treatment, to your touch.
Exactly. And often what they think is the problem is a product of all the sorry, I'm a little crass, all the garbage stories that everybody else has told them. I know that I've got my work cut out for me when a patient comes in to see me and said, well, my last therapist said, and that here comes the nocebo, here comes all the crap that they're going to tell me about what somebody else told was wrong with it, right? I love a clean slate when you get somebody for the first time, but nobody's devoid of beliefs and thoughts of what's wrong with them, right? They blame their posture, they blame their weakness, they blame their computer or phone or whatever, right? And you know what? I don't dispel those myths or those beliefs. It's just, okay, that could be true, but can we allow you to look at your cell phone and have less neck pain, right? That's really what I want to do. So let's bypass what you think it might be. Sure, we can look at that if you want, but can we move on to something that you find would be useful instead of looking at blame and all those other things?
Amazing. It's like you're diffusing the unhelpful belief, and in a way you're working with it as opposed to dismissing it completely.
Exactly, right? I would never dismiss it, even though I might think, God, that sounds kind of silly. But to that person, it means a lot. It has somebody in their life, whether it's their doctor or their last therapist or Dr. Google, somebody in their life told them that this was what was wrong with them. I don't want to be the person because I don't know if it's not, right? It might be, it might not be, but can we do something right now in this moment that you feel is helpful?
Awesome. And looking back to you mentioned it took about 10 years before or it was a process of 10 years to change your practice. Did I hear you correctly?
Mm-hmm.
Roughly?
Gradual. Yep. I mean, I kind of toyed with how different models felt, that neurological, that skin-based, that DNM, dermoneuromodulation model. I owe a lot to Diane Jacobs, to kind of holding my hand, if you will, kind of crossing the bridge from the MFR-based approach to at least the neurocentric approach. And, I think Diane's got a lot of really interesting ideas in terms of, first of all, what are we touching? And can the skin that we're touching, can that explain some of the changes we see in our patients? And I really do think it does explain a lot. Is it all of it? Probably not. But I owe a lot to people like that. It was interesting. It was hard. I got a huge amount of pushback from my old community for the healers that they say they are. They're nasty when they're provoked, but I guess we all are when we have to defend our turf. So it was a hard 10 years, but really meaningful and in the long run beneficial for me and my patients and hopefully the people who train with me as well.
It's awesome. So you were met with a few barriers with people that identified with the narratives with your in-group that you belong to. And it sounded like you were even a part of that in-group from the start with the evidence is on Soma Simple. Was that?
You mean the first one when I was when I was defending my turf, defending my mentor? Absolutely. Yeah. We the myofascial community, there's a body of evidence that we use and they still use to support that work. My issue with that evidence, my issue with the trigger point evidence, my issue with the exercise evidence, my issue with all the rabbit holes of evidence is, you know what, you start looking around and you start seeing what other people are doing and they're having success as well. If it's all about the trigger points and only your evidence is good, why is it that somebody else doing totally different work is helping people move along in life too? And I think that was one of the greatest lessons for me is take a look at what other people are doing. And I may not want to become that person in terms of how they do it, but I can't be in this vacuum perceiving that I've got all the answers. And I don't think any of us do. I think a lot of us learn recipes based on some of that information that we can take to our patients and help them. I think that's a really good take-home lesson.
And
what's for me?
Recipe. Yeah, and so there's more than one recipe as well. So it's a way to reflect on your own biases as opposed to thinking that you have the best recipe.
Absolutely, yeah, absolutely. And there's lots of recipes I don't even know about that people are helping. You and I see stuff on the internet every day that sounds crazy. It sounds hokey. It sounds gimmicky. But they're selling it, they're marketing the whole thing, but I'm sure they're helping people too. And is it placebo-based? Is it tissue-based? Is it weakness? Who knows, right? In some ways, that gimmicky type of intervention is helping someone. Not that I want to become a gimmick, because I don't think that's genuine and valid for patients, but a lot of different works work.
And we're taught a lot of students, new grads are brought up in a system of thinking that there is only one way, or there are certain answers to the exams. So, so looking at the way that you teach and how you help people, how you demonstrate your learnings and your approach, what are some of the challenges that you find with people that expect that kind of certain framework, that one recipe that answers all their questions?
Yeah. Initially they're disappointed. Initially they're irritated. Initially they're kind of pissed off at me because I'm not feeding them on a plate a certain story, right? In the seminars that I teach now, and a lot of them are my neck, voice, and swallowing disorder seminar, caters to the needs of the speech pathologist, the speech therapist, but I get a lot of physios and massage therapists coming to that class as well. So picture a class where you've got therapists coming in on one side with a lot of prior experience in manual therapies, right? And then you've got a whole group of people coming in with little, if any, experience in manual therapy, right? Because the people with all the experience are challenged in a way that they really start to vibrate in a really negative way. It's like, you know what, you're really challenging everything that I've not only been taught, but that I've witnessed, right? Because I saw the story that I learned in MFR working with people. People got better, which seemed to validate everything that I was taught. Unfortunately, that's not how it works, right? So you got people coming in there who I'm trying to sort of talk away from the edge of the cliff of all that. And you've got people coming in from the other side with no manual therapy experience. And I'm teaching them this generic, fuzzy way of touching people that's demanding feedback and not saying, here's what I'm doing to your tissue. It took me a while to get comfortable kind of in the middle of those two extremes, but now I kind of thrive on that. Just let's start from scratch. What do we know? Who's in front of us, right? What's their problem? What's their story? As you asked me, right? Because I think the narrative, the story is hugely important. And it's what I leave a lot of time for with my patients. And I leave a lot of time for in my seminars when I'm teaching people.
And sometimes maybe we need to respect the narratives that our colleagues have or that the people, other clinicians have, and treat it I don't want to say treat them like a patient, but just respect their time, respect where they're coming from, and work with their narratives and kind of guide them towards more helpful, less false, less wrong narratives.
Yeah, I had a bunch of years ago, I taught a class and there was a new grad doctor physical therapist came to the class, and he had been well schooled in pain science. He'd been hanging out on social media and seeing some of the common forums that we're all on. And he came to the class, and here he is, a brand new grad working from a model predominantly informed by pain science. And a lot of it was non-contact based intervention. And he told me the reason he took my class is he liked, I'm paraphrasing now, he liked that my approach was non-denominational. I didn't view it as a story, the dogma, almost the religious fervor that tissue-based stories are often worshipped with, right? He liked the way I taught the work, and he felt that the work that he wanted to do based on pain science, yes, it could be exercise, but there are times when touch helps, when manual therapy does seem to have an impact. And he was looking for an easy, well, not an easy, but a non-denominational way to include manual therapy into his pain science perspective. And I thought that was pretty cool.
And the narratives that you'd use to explain that to say your colleagues, so for the therapists out there, so there's huge power in putting hands on someone. You're engaging what is meaningful to them. You're engaging the nervous system, the structures, obviously, but them as a whole person. What are some of the narratives that you use to explain the mechanisms, the awesome effects that you can see in clinic?
In terms of to a patient or to another clinician?
Let's talk for a clinician. Okay.
From a clinician, I start with about an hour-long lecture on the could-be's, right? It could be the tissue stories. We briefly unpackage a few of the tissue stories, but those are probably, even though they're the most popular in our fields, they're probably the least credible when it comes to the actual irrefutable evidence, right? We take a look at the nervous system perspective, the extraspinal, the spinal, the brain center type perspective. We take a look at placebo. We take a look at sympathetic changes. We take a look at that. I just could refer to it as a cascade of possibilities. All the way up the chain from cutaneous nerves to, tunnel syndromes to the brain itself playing a big role in all this. There's a couple of papers that I really love to quote when it comes to the brain's influence in all this. And one, if your podcast population tends to be more physio-based, it might be a paper that they've not seen. It's a 2019 paper by a speech pathologist by the name of Nelson Roy. And he did a paper on muscle tension dysphonia, which basically is hoarseness, right? Hoarseness was viewed or is viewed as given the description of muscle tension dysphonia, dysphonia being poor voice, right? The view that there's too much tension in the laryngeal musculature. And the intervention is manual circumlaryngeal work, which is some moderately aggressive manipulation of the larynx. Originally viewed as we're reducing the muscle tension in the larynx, right? But then over the course of the last 25 years, the research has moved from it's all about the things that happen here in the throat, and the parallels are uncanny when you look at the evidence in our field, right? Whether we're working in the throat or the foot, right? The thought that what we're doing here, the impact is felt and received and processed here, right? What Nelson did was he slipped his patient into a functional MRI machine, and they took a look at this person's brain when she spoke, and they saw parts of her brain lighting up that they wouldn't expect, and they attributed that to the muscle tension dysphonia. And it's a multifactorial paper, not just the manual therapy part. But the cool part of that paper is while she was in the MRI, they did the manual circumlaryngeal work, and they literally watched her brain change in response to the input we were giving down here, right? They watched the brain change to back into more of a normal brain highlighting type of what should be lighting up when the person speaks. And to me, that's not just about voice and muscle tension dysphonia. I think that in a nutshell, that may sum up a lot of what's happening when we do manual therapy, that we're giving input in the periphery, but it's the central processor that's paying attention and potentially creating and contributing to the changes, be it pain or function or whatever that might be. And to me, that paper is a game changer. And I really like to see that sort of model come into the physio profession in terms of people doing work under those circumstances, because the adage, what happens in Vegas stays in Vegas, is a popular statement here in the United States, right? The thought that what we do here stays here is just so untrue. And I'm guessing most new grads have an idea that, there's a lot more to it than the tissues. But I can tell you, at least in my country, with a lot of the people I encounter on social media, it really is easy to sell that what happens in Vegas story stays in Vegas. All right. So papers like that have really gone a long way to show me different possibilities. While we're on the topic of papers, there's a couple other papers that I've just come across recently. Joel Biolowski has written a couple papers talking about mechanisms of manual therapy, modeling an approach over the last 10 years or so. He's written some really neat papers taking a look at the potential, again, the cascade from the tissue-based story to the extraspinal, to the spinal, into the brain influence that might be at play when manual therapy is done. And taking a look at some of his graphs and his charts in his papers, it's a simple way to represent not just to clinicians, but maybe even to patients, that it probably isn't just about that scar or that trigger point or whatever you think is wrong here. Or if we're talking about the exercise-based community, the strength people, right? It's not just about, okay, you're having a problem because you're weak, we need to strengthen you there. I mean, I want to see those narratives go away as much as I do the tissue-based story, because to blame somebody's pain on weakness, I think is lazy. I think it's dishonest. I think to say, get stronger and life will be good. Yeah, exercise helps, but seldom is it due just because we made that muscle stronger, right? There's so much work that needs to be done in our professions. And, at least in terms of the manual therapy aspect, I hope that I'm sort of, pulling the plug on a lot of the old stories that are out there.
I think that it would be interesting to see what the future holds. And it's frustrating that people still perpetuate these narratives and perpetuate the post hoc fallacies. It's in our world. So I'm an exercise professional. It's in the exercise physiology world. This is tight, therefore you need to stretch this. You need to strengthen the opposing side. It's like, we're not puppets. We're humans. We're biological beings. There's more than one reason. I think it's so the reductionist narratives. I don't know. Do you think in future there's some hope for the kind of holistic, person-centered approaches, the updated narratives? How do you think the future will hold with? Yeah.
Yeah, no, I definitely think so. I think it's the demand from, the education process that therapists are going through now. Unfortunately, when you get out in the clinic, and I can't speak to your country, but I know my country, I mean, I get a fair amount of patients. I have a small one-person manual therapy practice here in the upstate New York area. And like all of us, we get people who somebody else didn't help, so they come and see us, right? I mean, that's not uncommon at all. But the times that I'm guessing you hear, my last therapist said, I'm having back pain because I'm weak, right? I just think maybe the therapist actually said those words, right? Or maybe that's what the patient interprets or took from that message. And some of it may be, I, as a therapist, know it's more complex than that, but I got to tell you a simple story to get on with things. I think that's where we do our patients a disservice, when we dumb things down too much. And that's what I really hope for our shared professions, whether it's, the physio or all the other communities that I get a chance to engage with, is that over time, we allow ourselves to understand that it's much more complex and figure out elevator speeches to be able to explain that to the patient. The one thing that I do when it comes to explaining something with a patient is I'm trying to figure out, well, by listening to their story, right? What do you think it is? Daniel, you've got this problem. What do you think it is? And that becomes a product of all the different people who told you this, or your own beliefs, right? I'm hearing it, I'm absorbing it, and in a way, I'm going to use that as part of the explanation. If you think, I'm going to pick on trigger points because they're easy to pick on, right? If you think you're having that pain because you have trigger points, I'm going to at least acknowledge your belief in your past and what somebody's told you, because eventually they're going to say to me, well, what do you think's wrong? Right? And I may say, Daniel, it could be those trigger points that your doctor says it is. It also could be a neurologic remnant that your brain simply hasn't let go of an injury you had in the past. And so I give them more than one possibility. It could be that, it could be this. If they need more, I'll give them more, letting them know that there is uncertainty. But that's the point where I turn it, instead of the mirror being pointed at me, giving them all the, the diagnostics, I turn it around and I put it at them and I say, it could be this, this, and this, but what do you feel right now? As I put my hand on you and I put pressure here, or I stretch this, or I do something manual therapy wise to your body, what do you think, right? Which is not always hard because they're paying me for my story, right? They're paying me for my expertise. They want the full Monty of it, right? But I try and get that mirror turned around and it's like, okay, it could be that or that or that, but ultimately we're trying to make you feel better. So when I do this, Daniel, does that feel relevant? Does that feel useful? Is there anything about this that feels dangerous? And if so, I'm going to stop it, right? I move them into the process of, let's get out of what you think you want to hear, and what do you feel right now? What's your expectation in this moment?
That's
not
great.
an easy process. Yeah.
Yeah. I love the words "it could be" and the awesome word "and," the fact that there could be more than one narrative.
Yeah.
And you're asking them what they think, and it's a process. So you're individualizing the story. You're individualizing the explanation according to that person. Just like we would individualize an exercise program, we would individualize our manual therapy approach. We'd individualize that explanation as well.
Yep.
So it's that
and I really think this kind of
approach.
Exactly. I really think the person-centered, the patient-centered approach could be applied across the board, whether it's a manual therapy-based approach or even an exercise-based approach, right? To me, one of the worst things I see is when the patient comes in with this long list of things that their last therapist or their present therapist gave them to do. And I ask them, what do you feel when you're doing it? And sometimes I say, I feel like I'm doing a lot of things that the therapist said should be good for me, right? And then I ask them, do you feel a connection, right? Because to me, if you're going to give a patient an exercise or a stretch or anything, I think that something up here should kick in and say, oh yeah, I can feel it. I feel why he gave me that exercise. Whether it's because it's addressing that area that I perceive as weak, or it's addressing that area that I perceive as tight. Something about the homework, something about the intervention that happens in our room, all of it should connect with the patient's perspective. So they say, yeah, I get this. I think that's one of the intangibles in our profession that doesn't get enough attention and credit, getting into the patient's perspective more than our perspective as the expert.
It's not about us, it's about them and what they think. So we're kind of adapting according to what they're saying, what they're telling us, and what they think is relevant. So yeah, I hate that laundry list of 10 exercises and the idea that more is better. Just a generic sheet of exercise that we see. It brings the profession down, and it makes people think that that's what to expect, because then they show that exercise sheet of paper to their friends and family.
Yep. And unfortunately, a lot of people don't like the words that I use a lot when it comes to clinicians, because I think that sort of approach is an ego-based approach. It's one that we base on our expertise, our training, our knowledge, which is our ego, right? And we're applying our ego in the way we feel best. And we can't totally eliminate our ego, right? It's a part of the process, right? But can we balance it with the patient's expectations? And that's the one thing that I call into a lot is the evidence-based model. When it comes to the work that I do and the work that I teach is, we need the evidence, we need our experience applying the evidence, but what about that ground floor of the evidence-based model? Truly 1/3 of the evidence-based model is patient perspectives and preferences. And I really think that is, it's just given lip service, at least the way I see manual therapy, physical therapy, speech pathology, occupational therapy, massage, like all of them, right? I see the patient perspective and preference really being a distant third. I truly believe that I'm elevating it to an equal weighting with the evidence that I use to support the work, my experience applying this, but then demanding that patient play a role.
And giving them the power. So you're empowering them with your words, and it's not like you're fixing them with your touch. So, so going back, yeah. So with just going back to your explanations, you're going from the tissue-based narrative into the neurocentric, into the therapeutic relationship, the context, the fact that you're creating a safe environment. if we were to pie chart it out, I know it's a perhaps a reductionist question now thinking about it. If we were to think of the main factors, say the priorities for the approach, where we have the therapeutic alliance, the safe contextual environment, and the other mechanisms, which ones would you prioritize in your encounter with a person, with a human being?
All of them. You know, I think the safe context of intervention, of touch, of permission based goes a long way. For some people, it doesn't matter much because they're already coming with that expectation. I think from, oh man, if I had to pick somewhere on the cascade, you know, we're using the tissues as a handle to get to the brain, to get to the perception, to get to the cognitive behavioral aspect of this. I don't want to discount tissues completely because we do use them as our handle, okay? I don't believe most of the tissue-based stories, even though I still have to sometimes tell a tissue-based story to people because that's part of what they're coming in with, right? I know some good tissue-based stories. I know decent neurologic narratives, but I think the behavioral aspect of the work is the most important, right? To me, the most important aspect is that when they get up off my table, they feel different. There's a difference that's felt. And somebody say, well, that's just going to be temporary. Well, I used to believe that to be true, and we do need to make help them make lasting change, right? But the goal is for them to get up off my table or wherever we're working and feel that something has been altered. And if they want to know what, sit back down because it's going to take a while to explain, right? Because the goal of my work isn't to make your fascia looser. The goal of my work is to help you move back out into the community and to move with less fear and greater ease, right? And I believe movement is therapeutic, whether you dose it as exercise or strengthening or dancing or running or walking, right? My goal is to get them up. So in moving more freely, and I think a lot of it really is cognitive behavioral in nature. Did I answer your question? I'm not really sure if I did. Did I?
In a convoluted way, yes. Yes, it did.
I'm good at that. I'm good at convolution. Yeah.
Yeah. There's never just a straight answer. So you touched on a lot of topics that were relevant, and with the kind of symptom modification that you mentioned, it you used to think that it was temporary. Could you expand on that? Where I'm assuming I don't want to make assumptions, but that kind of therapeutic effect can then, or you're hoping that it would affect their lives outside the clinic. It would get them engaged more in the movement, the thoughtless, fearless movement that they wanted to do or they had been doing before pain. Right.
Well, the reason I said that getting up off the table might just be temporary, some of it was based on some of the stories that I was taught, and some of which I used to teach in terms of, if we're going to go into that fascia rabbit hole, in order to make lasting changes, we need to get rid of the tissue memory out of the system. And it takes a while to get rid of that tissue memory based on the perceived properties of fascia. And while I kind of saw that happen in practice, I also realized that for a lot of people, that's a really damn good sales tool to say, this is going to take a while. It might take a long time because there's a lot of memory in your fascia that we need to unravel and unwind, right? And, oh yeah, I'm willing to do that. I really want to get rid of this. And you just created a vulnerable, gullible patient who's willing to buy into what you're willing to sell them, right? And I understand that we're all in this to make our living, and it's easy to sell people on what they're asking for, and it's easy to sell people that it's going to take a long time. So when they get up off the table, I used to tell a variant of, you know what, you may feel good now. I wasn't negative about it, right? But some of this might return. We just need to keep at it, right? Now, when they get up and they say, well, I feel better, but how long will it last? And I say, well, I don't know. Why don't you see how long it lasts? Because I believe right now in this moment, if you feel better, that maybe it is about the tissues, but it's about your brain saying, hey, maybe I'm not as damaged as I thought I was. Because I think that sort of message, that positive message that you're not as hurt as you thought you were, may play a big role in allowing you to move through this faster than you think you may have, all right? So, you know, in life, I'm a glasses half full person, and I've kind of taken that now to my clinic as well, that, you know what, it might take more, but just appreciate right now how good you feel and go out there and do things differently. One of my favorite homework assignments for people, because when we're done, they expect me to give them the laundry list of things, right? And whether it's, you know, a whole bunch of stretches or a whole bunch of exercises, right? And they say, well, what should I do to keep this going? And the thing that I'll say to them often is, well, I think that one of the biggest things you can do to keep this good feeling is to appreciate that you can feel good, right? And when you wake up tomorrow, if you feel good, it's not like you need to thank anybody for it, but just pay attention to that and say, okay, here I am. I'm doing better again today. Reinforcing the positive instead of the fear that if you don't do all these things, you're going to regress back into that place you were. And yet, you know what? Our exercises, the strengthening, the movement, the stretching, et cetera, all those might help. But sometimes I think the changes that happen, they take place up here as much as they do down where we think they do.
Bit of the cognitive reframing that leads to the long-term changes, you'd say?
I believe so, yeah. And, you know, everybody's different. We have to treat everybody as the N of one. What is this person? What do I need to do for them? What do I need to do with them to help them? And, you know what, we've got a lot of different strategies at our disposal. And sometimes I'm reaching into that tool bag and trying lots of different things. Sometimes you nail it on the first time. Sometimes we don't nail it at all, but I'm willing to keep trying.
And so what would you suggest then for the manual therapists out there who are delivering these passive interventions to still make sure that that person kind of develops that independence, that self-efficacy after the session?
So I have to laugh at the phrasing of the manual therapy as a passive intervention, because I recognize that from a couple well-known people on social media, that in terms of manual therapy being ineffectual because it's passive, it never engages the patient. And I think if I frame the environment here so they're laying on my table, receiving everything, they get off, and there's nothing more beyond that, I think it is a passive intervention. But if there's a simple switch that turns on when they're done with this quote unquote passive intervention and they feel like they can move easier, it instantly becomes active to me, right? It's not active in the way that we're loading people's joints or giving them all sorts of strengthening things, right? But the active part of it is if they get up off our table, right, from that passive intervention, and they feel that they can do things easier, smoother, or better, I think activity, the active component immediately comes into play. And that's the one thing that I would stress in terms of if you're doing nothing but passive, realize that what's your goal? Your goal, sure, it might be to help them get out of pain, but what will that help them do? To me, as a physical therapist, that's basic goal setting, right? It's like, what's your goal? If your goal is to reduce pain, that's lovely. But I think reducing pain in and of itself should be attached to something active, something functional, right? What's the functional outcome that the patient's seeking? It could be just pain, right? But I like to go a little deeper. I like to pull a little harder. What would less pain allow you to do? There comes the active component of manual therapy, right?
Love it. It's a collaboration between the therapist and the patient. It's not like they are lying asleep or they're just kind of distracted from the pain, from the symptoms. You're involving them in the process. You're asking them questions that make them think a little bit, or that give you that information that makes it meaningful to them. And then you're providing them a narrative that is empowering, is less threatening. You're not giving them exercises just for the sake of doing exercises as well. And they're leaving feeling better, and they're leaving able to do the things that they want to do, or doing the things that they would be doing had they had no pain.
Right. And they're going to need coaching, right? To some degree, they're going to need our ego to come in and coach them in terms of what can they do? What should they do? What might they do, right? Some people, it's like the bell curve. Some people, they get off the table and they say, I can run again. And they go back out and they do that. And you never see them again until it's at the grocery line, right? Something like that. Other people, they need coaching. They need their handheld. They need the stretches, the exercises, the strengthening, et cetera. I don't do that strengthening model here in my clinic, but we talk a lot about movement based on their perspectives. for a number of years, I shared office space with an independent orthopedic surgeon, and she had we had a sign in our waiting room that one of her kids had drawn for her. And the sign said, the best exercise is the one you'll do, right? The best exercise is the one you'll do, not the one I tell you to do, right? But the one that you'll do because you love doing it. So let's make that active component something that has great meaning to the patient versus something that I think from my ego is good for you or important.
Love it. Love it. And it's not, it's not just because we like strength training or just because someone else likes Pilates, just because another person likes yoga, doesn't mean that we have to instill our own biases to that person.
Exactly.
Amazing.
Yeah. Not that it hurts to offer it up, right? If you believe that strengthening is effective, right? My guess is that patients self-select before they walk in your door. They've seen your website, they've heard feedback, they know that Daniel's an exercise-based guy, right? They're not walking in expecting my warm fuzzy table approach, right? Because people walk into my office and seldom do they run screaming because I don't have exercise-based equipment. They've seen my website, they've watched some of my videos, they've gotten feedback from people. They self-select by walking in my door and saying, you know what? I want to try what you have to offer me, right? And to think that because you're an exercise-based therapist and all your patients get better, you assume that therefore that's the best. That's really limited. Just like the same thing applies to somebody in my role. To think that just because we help patients, to think that applies to the bell curve of humanity, I think is really short-sighted. Right? There's something out there for everybody, and they need to shop us, right? They do shop us.
100%, and it's their choice as well in terms of the interventions. It's their choice in terms of the people they seek. So the private healthcare world, and the marketing involved in it. So there are people that aren't ready for the active approach. There are people that see a few weights and they run away, as you mentioned. And there are other people that are perhaps more of they've already got that exercise background. They respect someone in that field already that's knowledgeable in those sporting areas. So there's a whole, like you said, it's a bell curve. So we're targeting and we're offering our services to help everybody, not just the people that we like or that like us or that fit our biases. Awesome. And I've got one last question for you, Walt. I respect your time on the other side of the world as you get on with your busy day. We've got what advice would you give to physical therapists, we'll say, in the field who come across evidence that goes against their beliefs?
Embrace it, right? We're always going to find it. If you only read the evidence that supports your bias, right, you're never growing or learning. I did that for years. And it's not until I started looking at the evidence that conflicted with my bias that I think I really started to grow. And I think there's a lot of good information out there, not only in our physio profession, whether it's the exercise or the manual therapy perspective, but moving beyond into other domains, other disciplines, even the cognitive behavioral type of approach, to see that there's a lot for us to learn and ways we can apply it to patients. So when you come up with conflicting evidence, you know what? Chew on it for a while. Don't immediately discard it.
Amazing. And become aware perhaps of the biases that you have as well going into it, so that you develop that critical thinking skills that you mentioned that it took a while for you to develop. It took quite a few years. Yeah.
And I'm still learning, and I'm still growing, and I'm still, realizing that I am working from my confirmation bias constantly. But you just kind of undo some of those old messages, and it is a process.
Amazing. It's not a destination. It's a process. So
there you go.
Well, yes. Well, thank you so much for your time. And I know there was a lot of valuable takeaways there from not only the people that are biased towards manual therapy, but also the exercise professionals like myself, to see what kind of narratives are out there that are helpful, what kind of reframing the passive interventions as not just someone lying down on a table and expecting to be fixed.
Right.
And working with people to know that there are people that aren't ready perhaps for the active approach. There are people that would suit different approaches, and there's more than one way to skin a cat, as they say.
Right. Right.
So,
and if you'd like, we can link some of these papers from in terms of this podcast as well, if anyone's interested in any of the papers that I talked about a little earlier.
Absolutely.
All right.
We'll
All right.
definitely.
Thanks, Daniel. Appreciate your time.
You're more than welcome. Thank you so much, Paul.
Okay. Bye.
Bye-bye.